Good evening, ladies and gentlemen. This is Dr. Heba Barakat, Healthcare Programs Manager at AUC Executive Education. I hope you are all keeping well and staying safe during these testing times. It's an honor to welcome you all to our webinar today, which is amongst our Business Reconfigured Healthcare Track webinar series we are launching in the upcoming period, including COVID-19 infection prevention and control on the 2nd of July. You can join by registering through the Executive Education Facebook page or the Executive Education website. Before we begin our webinar session today, I would like first to share some engagement tips that would help enhance this webinar experience. Please keep your microphones muted so we do not experience any noise distortions. Please do not open your camera or start a video so we maintain a smooth streamlining connection. We have ample time at the end of the session to answer all your questions. So please park all your questions till after the session so they are structured comprehensively and in relation to the entire discussion. During the question session, if you have any questions, please write it in the chat box addressing Heba Montasir. We want to stick to the time designated to this webinar and wrap up at 8:30 p.m. today. Today's webinar session will be on COVID-19 healthcare quality preparedness, from standards to implementation, featured by Dr. Islam Abou Youssef and Dr. Shaimaa Elmeniawy. Dr. Islam Abou Youssef is the Vice Chairman of GAHAR, the authority that leads Egypt's strategy in accreditation and regulation of all healthcare facilities and healthcare professionals. He has over 17 years of national and international experiences in quality management and patient safety. He's an instructor of MBA and JCI quality program. We hope you will enjoy today's webinar. Dr. Islam, the floor is yours. Dr. Islam, the floor is yours. Dr. Islam, can you join, please? Dr. Islam, can you hear me? Dr. Islam? Dr. Islam, can you hear me? Dr. Islam, do you have a problem with the connection? Dr. Islam,
can you hear me?
Now we can hear you. Yes, please start.
Can you hear me?
Yes, please start, Dr. Islam. You can start. Yes, you can start. Dr. Islam?
I hope you are hearing me all. Responsible for registration and accreditation standards development for healthcare organizations in Egypt. I want to confirm that you hear me, Dr. Heba, please.
Yes, yes, we do, Dr. Islam. Yes, we do. Proceed, please.
Okay. GAHAR is the organization responsible for the development of healthcare accreditation standards and for regulatory control for healthcare organizations and health professionals in Egypt. Sorry for. Should COVID-19 crisis affect the quality of healthcare? In fact, before we answer this question, we should have a look on this bar chart. This bar chart published in Chest Journal in 2014, it shows that we have three modes to respond to crises like COVID-19 or any pandemic, actually. The first response is called conventional response. And in this, we can increase our capacity by not more than 20% of our ordinary capacity. The second response is called contingency response. And in this level of response, we conserve, substitute, adapt, and reuse some of our resources. And we increase the capacity by 100%. So we can say that we double our capacity. In the third mode for response is called crisis response. In this surge response model or mode, we triple the capacity. So we conserve, substitute, adapt, reuse, and reallocate resources. In the three types of response, we can find that the quality of care or the standard of care identified by this arrow and the line corresponding to this arrow, it is minimally or not affected in the conventional mode of response, but it is slightly affected in the contingency surge response and markedly affected by the crisis mode of surge response. So the answer to the question 19 can affect the quality of care, but this should be correlated to the level of response we are in. So it's not acceptable to have very low quality of care while we are just in the conventional mode of surge response. And to have these results, actually, we need to be prepared. We need to be ready for these kinds of crises or disasters. And if we are not ready, we may face this condition. So the standard of care may be dramatically affected even in the conventional mode, because simply we may not be able to conserve or substitute our resources. So we need to be ready with disaster management and crisis management plan in order to sustain the highest level of quality for our patients. Accreditation standards and issues like COVID-19, we will find that most of the accreditation standards in general and GAHAR accreditation standards particularly, they address issues like epidemics and pandemics, such as COVID-19. For example, you will find most, if not all, accreditation standards, and particularly GAHAR standards, they address the issue of disaster and crisis preparedness and management. Also, they address the issues like risk management, patient flow to prevent mixing and patients, infectious patients and non-infectious patients, to minimize the interaction interactions between patients and non-caregivers from the employees in the organizations and so on, and to even prevent the mixing the lines of flow between patients who are not from same categories when applicable. So patient flow standards are there. Also infection prevention and control standards, which are the main issue to fight things like COVID-19 or any pandemic. We will find standards addressing hand hygiene, antiseptics like alcohol, alcohol-based hand drops, and etc. Personal protective equipment such as face masks, face shields, gloves, etc. And methods to prevent transmission of disease like isolation precautions. Also, standards address the resources and supply chain management, particularly in times of disasters and crises. In times like pandemics and epidemics like COVID-19, we will need to manage resources efficiently. Staff safety and education. We have standards addressing this issue. Staff safety is crucial in issues like these situations. Also, coordination with other facilities for transfer of patients, because whatever our capacity and whatever the surge response we go for, conventional, contingency, or even crisis, we will stop at a level where our resources cannot tolerate anymore. So we have to coordinate with other facilities to transfer patients and to maximize or create opportunities for care of our patients. These are generally the standards or the topics addressed in accreditation standards, which are related to issues like COVID-19 pandemic. These are examples, particular examples from GAHAR Accreditation Standards 2019, the edition which was released last year for hospital accreditation in GAHAR. We will find that, for example, EFS 12, it's a standard addressing the issue of emergency and disaster management plan. And we find if we have a look at this standard, we'll find that talking about internal and external emergencies, the response for these emergencies and preparedness to be ready, and including epidemics, natural or other disasters that address risk assessment, personnel recall system. So to maximize the use of our resources, we may need to recall some of our staff from vacations or things like that. And alternate resources, medical supplies, utilities, etc., and communication. So these are the main components of disaster and emergency management plan required by GAHAR. And by the way, GAHAR standards require that the organization test these plans and do drills routinely to check and make sure of the effectiveness of these plans. Another example from the infection prevention and control, in fact, EC2, it's talking about that the infection prevention and control program is based on risk assessment. It has qualified individuals having overseen the program, and a lot of requirements for the infection prevention and control program. One of them is that this program or the action plan of this program is based on risk assessment. So risk assessment can identify where are the areas that needs to be more addressed more in the infection prevention and control plan. ACT4 is talking about the risk assessment and management plan. Also, it's talking about multiple scenarios of patient flow. So if the ordinary patient flow is designed in regular time to be done in a special design, we need to change this patient flow at the time of disaster. And if this disaster is a kind of epidemic or pandemic, so there are some infectious patients and non-infectious patients, so this should be taken into consideration. IPC 5 is talking about the policies and procedures that addresses the precautions to prevent infections and improve practices, infection-free practices. such as hand hygiene, selection and using antiseptics and disinfectants, also the availability of personal protective equipment, such as face masks, face shields, and all types of masks, depending on the need for patient or for staff, as well as cleaning activities, including environmental equipment and supplies cleaning. IPC 10 is talking about the strategies or mandating the strategies to prevent transmission of contagious diseases or infectious diseases. So we will have we have two components in this standard in IPC 10. One of them, the first one, is talking about transmission-based precautions, such as contact, droplet, or airborne precautions, and things like COVID-19. We can deal with it as droplet-based precautions, and in very few cases or few circumstances, it should be dealt with as airborne. But all these are based on approved guidelines, the approved guidelines. Ministry of Health and the particular institution or hospital. Also, it is talking about precautions for immune compromised patients, high-risk patients, in a situation like COVID-19 for patients with chronic diseases, elderly, and so on. OGM 14 is addressing the issue of supply chain of resources. So you will find that this standard, OGM 14, is requiring that the organization manage stocks safely and efficiently, and the inventory management and tracking the use of critical resources. So here, the standard of resources and management of and tracking of critical resources. And in times like COVID-19, we have this issue of having some critical resources which may be not easily found. ICD-4 and ICD-40, both of those standards are talking about very important things. The first one is talking about the urgent and emergency services, such as emergency care or ICU or intensive care for patients, which is the main service in hospitals facing the shortage in time of COVID-19. This standard is talking about having these services ready and managing patients in these setups according to approved guidelines and protocols. Also, the ICD-40 is talking about identifying and ensuring that we have the emergency equipment, supplies, and these equipment supplies are appropriate to the patient's age and conditions. OGM 12 is talking about what we call staff safety. Staff safety is very important, very crucial in situations like this. So OGM 12 is talking about workplace cleanliness and safety and security measures. So providing staff with safety while working is a requirement in GAHAR standards 2019 OGM 12. Workforce Management 9 also is talking about infection control procedures to protect staff and environmental safety plans and occupational health hazards and safety procedures. So both of those standards, the OGM 20 and WFM 9, are there to protect staff in regular situations and in crisis times like pandemics and epidemics like COVID-19. So infection control procedures, environment safety plans, occupational health hazard and safety procedures. The last in my example is ACT 12. At the end, we may not be able to provide all patients with care in one hospital. So you can increase your surge response from level to the other, and at the end you cannot provide care because you are fully occupied with patients, the hospital fully occupied with patients. So you have to have planning, ready-made plan to transfer and refer patients to take care in other organizations, either to refer or transfer patients, with the conditions, mild or moderate conditions, to other organizations, or to transfer even the infectious patients. So this is addressed in the 12 standard. It's talking about planning for transfer, referrals, and discharges with other appropriate organizations, and including patients and family in this. These are the standards, or the most related standards in GAHAR Hospital Accreditation Standard 2019 to this incident. What GAHAR did also in when the pandemic started, we launched an initiative called Together Always Ready. In this initiative, you can find about it, or you can access the components of this initiative in www.gahar.gov.eg. This is the website address. There are two main components in this initiative. The first is a self-assessment tool adapted to the Egyptian context, adapted from multiple sources, mainly including the WHO checklist to check the preparedness for COVID-19. It's called the Hospital's Readiness Structural and Operational Checklist. And also, we launched a training program, online training program, free. Both are free. COVID-19 Crisis Management online training program, it's free, and you can find both the structural and operational checklist and the training program videos in our GAHAR website, www.gahar.gov.eg. To conclude, the priorities while managing COVID-19, you will find these priorities already in quality standards, such as providing quality patient care and understanding that this care could be affected according to the level of surge response you are in. The second thing is ensuring staff health and safety. The third is business continuity. So you have to be ready with your disaster management plan or crisis and emergency management plan, and you plan for business continuity and plan for surge management, surge planning. And it is not understood and not acceptable, actually, to have low quality of care while we are in conventional mode. We are not doubling the capacity or tripling our capacity. You can substitute and conserve resources, but provide quality care. But when you are doubling or tripling the quality, this may affect the quality of care, and this could be understood at these in these levels. Coordination through incident management center with other hospitals or authorities, it's crucial, actually. And this coordination should not be reactive, should be proactive. So in your disaster plan and disaster and crisis management plan, you should identify the nearby organizations and the main authorities that you should work with in times of disaster in each type. So in the disaster management plan, you identify what are the types of disaster. For example, in epidemic or pandemic, there will be actions may be different a little bit from explosion or mass casualty or violence or whatsoever, or natural other natural disaster. So you plan your actions according to the needs and the context of each disaster or crisis. And you have a ready-made list for contact, the address book for each of the organizations you may refer patients to, and it's better to coordinate your plan with these organizations' plans as well. Timely decision making is very important. Timely decision making in crisis response is very, very important. These are the main priorities in disasters and crises like COVID-19. Thank you.
Thank you, Dr. Islam. Now it's time to invite Dr. Shaimaa, our next speaker. Dr. Shaimaa is a quality director and quality education programs director at Children's Cancer Hospital in Egypt, 57357. She is the JCI Quality and Patient Safety Program Director. She is a healthcare quality and hospital management consultant for quality and accreditation projects for many renowned healthcare organizations. Dr. Shaimaa, the floor is yours.
Thank you, Dr. Heba, for the introduction. I am Shaimaa Elmeniawy, CCHE 57357 Quality Director. Today, I will be sharing with you our hospital experience during COVID-19 pandemic. CCHE 57357 is a pediatric oncology hospital. It serves patients from 1 day to 18 years old. We serve all type or kind of services for the oncology patients and pediatric patients, like radiotherapy, nuclear medicine, radiology, surgeries, all multi-specialty clinics. We serve an immunocompromised patient, which is a very high-risk population, and we are a very busy hospital. We faced many challenges during the implementation of our preparedness plan. One related to screening and contact at first contact in the hospital. Second one, due to the number of patients we serve at the same time. Third one, facility management during COVID-19, staff reassurance, supply chain during COVID-19, proactive rapid communication. Our preparedness manual consists of many chapters to cover all the elements we need, like PCI chapters, crisis management chapter, supply chain, screening, clinical, facility, staffing, quality, awareness, surgery capacity, follow-up, staffing, assurance, training, and lab. The plan we already implemented are consisting of 3 levels based on the hospital internal situation and the external pandemic situation in the country. Regarding the first challenge is screening from the first contact. We distributed signs and the information displayed in the waiting room areas about COVID-19, ways of transmission, and the other information important to be known. Also, we distributed masks and screening for COVID-19 symptoms at the gates for all patients, staff, and relatives. Also, we had protocols for dealing with all types of suspecting staff and patients. Like this flow for suspected patient, when we screen at the gate, if we found the patient suspected, we already make him wear the mask, his parent by nursing staff. We direct him to the ER with security personnel, and the floating nurse take the patient and give him category 1 for triaging to be examined by the physician. If the patient is really suspected, he will be isolating in a separate room in the ER till we allocate a negative room pressure for him. If the patient relative is suspected, if the patient does not need an urgent care in the hospital and just a regular appointment, he will wait for another relative to accompany him. If the patient need an urgent care, both of them will be directed by the nursing staff available on the gates, at the beginning of the gates, to the ER department, where they will be isolated and managed by the ER team till find another lead. If the staff already suspected and all of us are screened at the gate from the beginning by temperature and the other symptoms, he will be directed to the chest clinic we have, and before the chest clinic, he will be directed to any hospital to be examined and take vacation, paid vacation, till he recovers. The second challenge is providing the same quality of service for the same number of patients, and we are a very busy hospital, and also taking all preventive measures for COVID-19. We serve, this is some numbers that show you how busy are the hospital and very crowded. We serve around 16,599 patients active per year, inpatient, outpatient, and other services. They come for all type of services. We receive 273 new patients every month. Average number of surgeries is 555. Average number of minor procedures, day case surgery is 1,200. Average number of OBD patients for ambulatory services like OBD examination or multi-speciality or taking daycare sessions for chemotherapy, 750, and each one coming with relatives. We conduct around 4,000 lab investigation per day, 300 number of radiological investigation per day, 1,000 number of dispensed chemotherapy medications, 8,000 of dispensed medication doses per day. To take preventive measure in such a busy hospital, it was really challenging, but we started to think with each other and collaborate to do it. We started with the very busy areas like cafeteria, as you see here in the picture. We decreased number of tables. We served the staff meals in their places, in their units. Also, we ensure social distancing in the place itself. We increased number of sampling areas because our patients, they have to take lab samples before they are examined by their physicians. And it's really busy area in the morning. We increased the number of 2 to be 4 areas for sampling. Also, we scheduled the OBD patient onto 2 shifts, morning and evening. And this was really challenging, but by patient education and communication by phone and messages, we managed to do it. Also, the security helped us to do it by organizing staff and patients entry to the hospital and allowing only with appointment to attend. We rescheduled all follow-up patients to be after COVID-19 pandemic, also scheduled elective surgery. We reviewed the multi-specialty clinic services like dermatology and cardiology and other supporting services to give only the urgent to decrease the motion in the hospital. Also, we eliminated the number of relatives or visitors with the patients to be 1 only. And regarding the inpatients visiting, we decreased it to 1 in the first stage. Second stage, we prevented the visits at all. Also, we preventing the changing of the relative attending with the patient at the inpatient area. We stopped all training and fundraising visits. We converted all our meetings into virtual meetings, and we eliminated the number of people smoking in the designated area to 5, and now it is stopped completely. We advise our staff to use the elevator, to use the stairs, and leave the elevator for the patient and the relatives. We allowed only 5 persons to be available in the elevators. We monitored all these measures by the quality team on a daily basis. And we use all risk management tools from risk identification and assessment, prioritization and medication control to achieve overcoming these challenges. Regarding the third challenge, facility management during COVID-19, and when we talk about facility, we talk about environmental cleaning, biomedical engineering, utility management, kitchen, and waste. Today, I will focus only on the additional actions that was really challenging during the implementation, and for sure, environmental cleaning as preventive measure is very essential to prevention of the spread of COVID-19. So we started by cleaning the wheelchairs after each use between patient and another, cleaning bathroom more frequent, even each hour it is cleaned, disinfection of external areas because the staff and some of the relatives and patients are sometimes touching the walls or the grounds, so we already cleaning and disinfected it every day. The ATM machine between users, the transport vehicles of patients after each journey, the counters of nursing several times per day, clinics between each examination and another, the stairs also each hour, the elevators each 2 hours, every 2 hours, and the chairs every hour. Regarding biomedical engineering additional action, and biomedical machines is really important and essential during COVID-19 because maybe the number of patients that need critical care will be increased. So there is a mechanism in place to ensure that our biomedical equipment are perfectly working and can be quickly replaced when necessary. The hospital depends on 4 oxygen resources already. We ensure that all resources are available, and we increase the stocks and contracting services and resources needed for that. All inpatient rooms are provided with oxygen connection. Biomedical engineering department also and team prepared an anesthesia machines to be used as ventilators when needed. The fourth challenge, staff reassurance. The pandemic is not only affecting patients, it affects staff. And in order to keep our business continuity as usual and give the quality service we need to secure and to assure our staff. And we started from the first beginning of the plan and pandemic preparedness plan. We identified the high risk staff to be protected, and they now working from home. We introduced employee self-quarantine policy based on the contact history and the health status. We provided psychological consultation and psychiatric consultation by our team to the staff in certain hours per day by telephone. Also, we had a plan in place to avoid burnout and maximum number of working hours to be ensured. We provided PPEs from normal PPEs to full PPEs according to the level of exposure, not overutilization or underutilization. We established a chest and the critical care and the isolation hotel for our staff. And this have been very, very efficient, and we used it very well with the staff and patient. We took a floor outside the hospital behind a building behind the hospital, and we established a chest clinic, critical care unit from 30 beds, and we rent 2 floors in a hotel in Faisal Street with 28 beds for patients or staff cannot apply home isolation at their homes. This is some of our photos of the preparation or construction of the critical care unit. And this is after it is ready for use. And this is the team managing the unit. And this is the hotel under preparation and hotel rooms for the staff and patients. Fifth challenge is about supply chain management. During COVID-19 pandemic, it's not only our challenge on the healthcare, it's a global challenge. We focused on 2 pillars to maintain as much as possible from the proper supply to continue our routine business, and we did not stop one day from our routine or from accepting patients. And the second pillar was the proper management for possible increased demand for essential supplies and medication during COVID-19 surge. To maintain the proper supply of routine work, we focused on communication, transportation, planning and analysis, and inventory control. For the second challenge, we listed the supply, and this document, I took only 2 pages of it, lists the supplies for which we need to increase our stock level to be done in order to improve our hospital preparedness during COVID-19 surge. Also, we had additional storage facilities for additional stock we need that meet all the good manufacturing and good storage practice and respect temperature and the humidity and cold chain standards. Adequate materials for isolation units and the ICU are available. Also, disinfection procedures are in place for non-single-use supplies. A proper amounts of cleaning and disinfection products shown to be effective against coronavirus are available and used and tested. The sixth challenge here is if you have a very good plan, you need to communicate all plan elements and protective and preventive measures to all staff and patients and relatives to achieve the efficiency and the effectiveness of this plan. We started communicating from the first day of risk assessment by risk communication. Stage 1, before preventing of any rounds in the hospital, we did daily round with patient and relatives to educate them about coronavirus. And at the second stage, or also from the first stage, we started communicated all messages we need through to employees via email, via WhatsApp groups, or to digital signage. We had a patient education channel, and we communicated videos about coronavirus, also about how to protect themselves or how to prevent transmission of infection. Here comes the quality professional role. Quality professional role is the preparedness plan project management from the beginning. They are the change agents. They are the quality and the standards persons. They should be initiating initiatives, conducting projects, and identifying, preventing, and improvement initiatives that help people to achieve what they need to do during the pandemic. Also, communication and compliance requirements. The methodology we used during COVID-19 preparedness plan or pandemic was lean. It is really simple and it's easy. I will discuss with you only 3 or 4 initiatives we conducted by using lean methodology. The staging of PPEs used across the pandemic period or the surge period was really effective using lean methodology. And this was by adopting WHO guidelines. The pandemic spread has placed a very high pressure on the available supplies in the hospital. So staging the process and following the WHO guidelines without exaggeration helps the hospital to avoid overutilization of a very precious resources. At the first stage, we used only face masks and PPEs for people dealing with suspected or immunocompromised patients and the staff suffering from respiratory symptoms, if any. The second stage, we did not allow any person to be in the campus without wearing masks. Hoka initiative used for all staff to be wearing masks from the doors, plan different flow and rooms for suspected patients, fever screening of all staff, patients, and guardians at the gates to prevent and control the spread of infection. We have used the visual aids to illustrate videos and sent on WhatsApp, displayed on screen to increase staff awareness, patient awareness, guardian awareness, reduce panic and staff reassurance, education to staff how to do gowning, how to discard PPEs, how to use supplies, how to do hand hygiene, every item they need to know. We use Kaizen cards for documentation for all the initiatives and for future learning and recognition of efforts made by all staff in the hospital. This is the photo where the photo of the team done this initiative will be putting. Also, this is the initiative title, the problem, the action, the effect, and signature. Finally, I would like you to know, to ensure that your plan is effective, you need to be proactive, you need to have risk communication, comprehensive, 360 degrees covering all elements, dynamic, follow-up and monitoring, rapid response. I will show you and share with you the videos we used for communication with the staff.
مستشفى سرطان الأطفال مصر 57-3-57 حصن الأطفالنا جواه، وعلشان يبقى الحصن منيع كان لازم تأمينه من لحظة الدخول. قياس حرارة وماسكات ومطهرات للجميع، الأطفال، الأهالي، الإداريين والأطقم الطبية، لا تهاون في حق أطفال. في 57-3-57 بنحافظ عليك وعلينا. بروتوكول تجهيز الكراسي لأطفالنا بمستشفى 57-3-57. الأول بيتم غسلها باللوفة والمية والصابون، وبيتم تجفيفها بفوطة مضادة للبكتيريا، ده التنظيف. لكن كمان بتتعقم علشان تبقى جاهزة لأطفالنا. في 57-3-57 بنحافظ عليك وعلينا.
Thank you so much. Thank you.
Thank you, Dr. Shaimaa, for such informative presentation. Now we will start the questions and answers part. So you can write down your questions in the chat box. First question is for Dr. Islam and Dr. Shaimaa as well. The participant is asking about the importance of collecting data data during COVID-19 pandemic regarding disease as registry and medication use, and what's the experience on national level from Dr. Islam and in 57357 for Dr. Shaimaa. We'll start with Dr. Islam.
It's very important to, first, thank you for the question. It's very important to collect data and measure, because this is the way how we learn from our experience. Collecting data, aggregating and analyzing these data, and reporting the findings to those who are concerned is important step. It's important thing to be done. For example, the patterns of stock of supplies, what we have can direct or affect our decisions in the PAR level for periodic automated replenishment level for these emergency supplies, and this can guide our decisions. Also, the data regarding the results of care can affect our decisions. For example, the use of some medications was recommended by some organizations, and the WHO, for example, came at once and recommended against using one of the medications. In Egypt, we continue to use this medication because our results are in favor of using it, not against using this medication. So we are learning. We are not learning from the experience of other countries. We are all learning the lesson together now. So what we know about this disease, about this problem, is 6 months only. We have this disease for 6 months only. We are learning all together. Measuring makes us taking our decisions independently, not following other countries in what they are taking to manage this problem.
Dr. Shaimaa, can you share your experience, please?
Yes, we collected data from the beginning of the pandemic or the crisis by regular means. If we are taking decisions based on supplies numbers, as Dr. Islam was just saying, we need to know our stocks. We need to forecast what we need. Also, to know whatever are we going to provide the same services or not based on the level of these stocks or other, like if we have limited number of staff, all of our staff are infected, how are you going to provide your services? So measuring is part of the process, but it doesn't have a separate process to be done. Also, we have research. We have 3 pillars to depend on: quality and education and research. This is our mission, and our vision are built upon it. So we have been measuring, we have been collecting data, and also taking decisions. And we have a clinical research team that help us in these items. There is connection error.
We can hear you well, Dr. Shaimaa.
Okay.
Okay. Dr. Islam, the question is for you. To whom these requirements or standards apply? For the private sector or the public sector?
Okay. First, let me talk about 2 things I was talking about. If we are talking about standards, it's applicable for every single hospital in Egypt. The example I was giving was from hospital standards, hospital accreditation standards, GAHAR 2019. It's applicable for any kind of hospital, not only private, not only public, for all. But the initiative, the checklist, it's actually for guidance, not obligatory. It's for guidance for the hospitals who want to do self-assessment. If of these hospitals are not adapting special tool or following the WHO tool, they can use GAHAR tool. However, the hospitals accredited by GAHAR or registered by GAHAR are mandated to use this tool for self-assessment to improve their preparedness for COVID-19 crisis. GAHAR is the authority responsible for setting standards for all healthcare providers in Egypt, not only for governmental institutions.
There's another question for you, Dr. Islam. I think it's related to the previous one. We all know the gap between the quality standards and the real implementation in hospitals. What is the role of GAHAR in narrowing this gap to get the best outcome and at least losses during the pandemics?
Yes. We know that there is big gap between standards and the practice, but the gap is not very difficult to bridge. It needs some effort. One of these, actually there are gaps, not only one gap. One of these gaps is the structural and infrastructural issues related to healthcare organizations. So while we started to our registration requirements, we emphasized on these requirements. So any hospital or primary healthcare center or ambulatory center or radiology center or whatsoever registered by GAHAR, the infrastructure and structure will be reasonable and safe for patients and for healthcare practitioners. For accreditation, there are some other gaps, such as the culture of quality, the leadership requirement for skills required for accreditation, and some other activities. We launched a program called EGCAP, Egyptian Certified Accreditation Professional, to create the capacity and the capacity who can bridge these gaps. Also, we are providing free of charge service called SAP, Organizational Capacity Building Self-Assessment for accreditation. So we go for organizations, we provide the tools and then the awareness needed for them to do self-assessment and know how to bridge the gaps. So using SAP program, Self-Assessment Capacity Building Program by GAHAR, and the EGCAP, Egyptian Certified Accreditation Professional, these are the initiatives done by GAHAR to bridge these gaps.
Thank you, Dr. Islam. The question is for Dr. Shaimaa. What are the action taken in case of discovering that physician cases are positive for corona?
This action differs from stage to another, and this is differs according to WHO and even MOH regulation and advice. At the beginning, the first stage of COVID-19 spread in Egypt, maybe I think in March, they were advising the staff to be isolated or the contact to be screened, and we did it. At the second stage, maybe in April and May, they told us that the contact person need only to wear mask if he is not showing any symptoms. If he is showing symptoms, he will be taking the route of infected patient. He will be screened and examined. If he is COVID-19, he will be isolated and managed. So it is according to the situation and the pandemic and WHO guidelines.
Okay, thank you, Doctor. Dr. Islam, how many hospitals are accredited by GAHAR?
First of all, GAHAR is not only accrediting hospitals. We are accrediting all kinds of healthcare organizations. So if we are talking about and also we are registering first, then accrediting. If we are talking about the accredited organizations, are 14. The registered organizations are 62. These organizations are mix of hospitals, primary care centers, pharmacies, labs, radiology centers, and so etc. Most of these organizations are in Port Said now, but we have organizations in Menofia, Cairo, South Sinai, and in other governorates. The number of registered hospitals is now, I don't have the number in mind now, but it's it's around 10 or 11. The number of accredited are just 2. One of them accredited by GAHAR, and the other one is recognized by GAHAR. It was accredited before the presence of GAHAR.
Okay. And the next question is for you as well. So how do you deal with any hospital or department that does not adhere to the standards?
For any organization that does not adhere to standards?
Yes.
Okay. For those who does not adhere to standards, like some organizations and some governors, without stating the name, they fail and they get the denial of having the status of being accredited or registered, and the registration and the accreditation is denied. They cannot get contracts with the Universal Health Insurance Authority. That's an issue. And the other thing is the law number 2 for year 2018, the Universal Health Insurance Law, gave us or mandates that actually in Article 36 to take or inform the concerned authorities to take the appropriate action. But this is only applicable for governorates where the Universal Health Insurance Law is being implemented now. So simply, it is not black or white. We have registration and denial, and we have in between conditioned registration also for accreditation. It's not black or white. We have accreditation and denial, and in between there is conditioned accreditation. But if they are very far away from our requirements and from our standards, they have the denial, and this denial gives them the 6 months opportunity to reapply for registration or accreditation, and we give them another visit to evaluate these standards. And if they are not compliant, they will not be privileged to be part of the Universal Health Insurance, which is actually the new health system in Egypt, and it will be the main health system in Egypt in 10 years.
The question is for both of Dr. Islam and Dr. Shaimaa. We will start with Dr. Shaimaa. What are the strategies taken by 57 to decrease infection rate among your doctors and nurses?
First of all, we advise the high-risk group we just talked about in the first challenge about staff reassurance. High-risk group to stay at home because they can work from home and not exposed to infection. We advise them if they found themselves exposed to any infection or feeling symptoms to tell us, and they take paid vacations till they're cured. Also, we had just a clinic and critical care unit to assure that our staff, if they feel any symptoms or ill, they find the place to be treated. And providing all needed PPEs based on the risk level they are exposed to.
Okay, and what about GAHAR strategies to decrease the infection rate between doctors and nurses, Dr. Islam?
Yeah, our standards, we have some standards related to this, as I showed to you. So, there are a couple of standards particularly talking about protecting the work environment and staff and making it safe and clean for them. And the infection prevention and control program, the requirements for this program in our standards is mandating to have the appropriate PPEs, personal protective equipment, and hand hygiene, disinfectants, cleaning activities, etc. Also, and Together Always Ready initiative, the structural and professional checklist, which is designed for hospitals to assess their readiness, particularly for COVID-19. There is a complete section in this checklist for staff to ensure their availability and to ensure their safety.
Thank you, Dr. Islam. Dr. Shaimaa, what's your policy for the sick leaves?
First, staff have to inform the HR and the medical department that he is feeling symptoms. Do you hear me?
Yes, Dr. Shaimaa.
Okay. First, we have to inform our HR department that we feel symptoms. And now we have chest clinic. They take an appointment. We do the radiology investigation, CT chest, and lab investigation. Then, if the patient, which is the staff at that situation, is COVID-19, he take his medication. He either get into home isolation. If he cannot apply home isolation, the connection is fine. Okay.
Yes, Dr. Shaimaa. Yes.
Okay. If he cannot apply home isolation, we direct him to the hotel. And if he need a medical care, we have 30 beds critical care unit. All the leaves are paid leaves. He doesn't pay anything.
Okay. Thank you, Dr. Shaimaa. Dr. Islam, the relationship between dealing with COVID-19 and Egyptian healthcare insurance system.
Yeah. Actually, this is a big issue. Talk and look how if we look for the whole world, we will find that that countries with perform better than countries without. So if you look at Japan, South Korea, or any country with universal health coverage, you will find that they manage this issue better than other countries without universal health coverage. So universal health coverage will be providing
I think there is a problem with the
response
Dr.
to
Islam.
However, we are still in the beginning. We are in the, yeah, I'm hearing you.
Yeah, we
are
can't
still
hear
in the
you well.
beginning.
We can't hear you well. Can you please just repeat the answer?
So I want to highlight that universal health coverage, countries with universal health coverage performed better than countries without universal health coverage, such as Japan, South Korea, etc. I don't want to name the other countries without universal health coverage, but in Egypt, universal health coverage is in its early beginning, actually. So it is not covering the whole country. It's covering the first phase governorates only, and particularly Port Said. So if you compare the care in Port Said to other areas, I think it was it will be in favor of Port Said, in favor of what is being done in Port Said. However, the responsibility of management of epidemics and pandemics and the preventive care in the Universal Health Insurance Law is not the responsibility of Universal Health Insurance Authority. It's the responsibility of the Ministry of Health and the state, the country itself, the government itself. So management of epidemics is the whole country of the government represented in the Ministry of Health, not the Universal Health Insurance Authority. I hope you hear me well.
Yes, Dr. Islam. Dr. Islam, do we have IMC/EOC in Egypt?
IMC, what you mean by IMC?
It's
Incident Management Center, you mean?
I believe so. The question is as is, yes.
If you mean Incident Management Center, there is Incident Management Center in each accredited hospital because this is required by standards. But if you are talking about a national issue, there is Crisis Management Center, and the head of this is the Prime Minister, actually.
Yes, he actually, the participant wrote down Incident Management Center or Emergency Operations Center.
Hi, yes. For incident management centers, it is required in the accreditation standards. And I want to tell you something. In the beginning of COVID-19, I remember 10 years ago, I was one in the team planning for crisis and disaster management in one of the hospitals. And in this plan, there was IMC, Incident Management Center, Incident Command Center, actually. And it was mentioned in this plan that this plan is applicable also for epidemics and pandemics, namely pandemics. And the surge response with its 3 levels were mentioned in this plan and practically written where to go if you want to expand your critical care service, the ICU, where to expand in contingency response, and if you want to expand more, triple the capacity, where to go, and staffing, how to increase the staffing, and at the end, if you want to transfer patients, that there was list of nearby organizations and relevant authorities and how to communicate with these organizations and the authorities to transfer patients. So all these are standard requirements, and the IMC is ideally placed in the organization, the hospital, and works in coordination and with authorities. But if you are talking about a national center, yes, we have the leader of this is the Prime Minister.
Okay, thank you, Dr. Islam. Dr. Shaimaa and Dr. Islam, what is the percentage of success in applying the standards to avoid spread of COVID-19, both in 57357 and in general in Egyptian hospitals, specifically public hospitals? We will start with Dr. Shaimaa.
Currently, you don't calculate how % you are applying the standards. You try to implement all standards all the time. And this is the role of the quality and the infection control team. Continuity of applying preventive measures and proactive approach, monitoring of these effects is highly essential. So if you request me my opinion, I think it needs to be 100% applied to prevent the spread of infection. As much as you can, you should apply the standards and maintain and provide follow-up and maintenance of that. Also, the organization invested in quality and patient safety during the previous years. They get the benefits now. They are ready. They know what they need to do. They know the infection control requirements, quality and risk management requirements, and paid off now.
Okay. Dr. Islam, please.
For this question, I don't have. But the preparedness in organizations is different from one to another. So for those who used our checklist, it's variable from 60% up to more than 80%. And for those who use the WHO checklist, it's the same. It's variable from one hospital to another. And for and regarding our accreditation standards, there is no analysis for these data yet, because simply we measure the accreditation, the compliance with the accreditation standard during the accreditation survey and later on with the regulatory control activities. But there is no comparative data yet. It's planned. There is a program we will launch for national dashboard of measures for healthcare services, but the data we have is not enough yet to do this. We are still new.
Just a reminder for everyone, if you have any query or question, kindly write it down in the chat box. So someone is raising the hand, kindly write down your question in the chat box. So the next question is for both of you, Dr. Islam and Dr. Shaimaa as well. We will start with Dr. Shaimaa. What are the lessons learned from COVID-19?
To invest in quality and safety, to make your environment safer, you need to ensure that your staff are protected to enable you to provide the needed service to your patients. So people who are investing in quality and patient safety, they paid off now. Protecting your staff will protect your patients. Applying quality and safety from the beginning will make you solid in such a crisis or pandemic.
What about Dr. Islam?
Yeah, I agree with Dr. Shaimaa. What Dr. Shaimaa presented is actually an example of how an accredited organization can respond for crises like COVID-19. So complying with accreditation standards make healthcare organizations more ready to deal with things like that. However, we learned new lessons from COVID-19 crisis. One of these lessons is we need to go for digital transformation and digital health as soon as we can. Although this is one of in the Egyptian strategy 2030, but we need to go for this even faster than 2030. We need to go for digital transformation, particularly and support the universal health coverage, because people who are covered will not face the problem of looking for very expensive care, and they will be in financial risk to in this situation. The other thing is we need to add some legislative issues to facilitate.
Unfortunately, Dr. Islam, the sound is interrupted.
The digital health. Yeah, sorry. I mean that the laws and regulations, the current laws and regulations, need to be modified to address the needs for digital health and particular sector, digital healthcare sector, and to go for and invest in development and training of medical staff and healthcare professionals, because we need them, and the shortage for in healthcare professionals may increase in future, because the demand for these types of jobs is increasing worldwide, and it will increase more and more after COVID-19 crisis. So we need to retain our staff and to make sure that we have the professions needed to fight disaster and do specialty.
Thank you, Dr. Islam. Now we came to an end of our webinar. Thank you, Dr. Islam and Dr. Shaimaa, for such an informative session. Thank you for the participants, hoping that you enjoyed and you gained a lot of information that will help you in your practice. You can still join our upcoming webinar by registering on Executive Education Facebook page or Executive Education website. We have a next webinar next Thursday concerning infection control, prevention and control. And you can join us as participants in our executive education healthcare programs, whether hospital management and operational excellence diploma or healthcare quality excellence diploma. Thank you, everybody. Bye.
Thank you.
Thank you.
Thank you. Thank you so much.